So hello everyone, good afternoon. I would like to use this chance to welcome you to this session this afternoon on tackling the tsunami on non-communicable diseases through strengthening health systems, governance, public health, and primary and surgical care. So you are very welcome. We are going to run through our session. I'll first go through a summary of what we are going to discuss, and then after I will introduce our speakers, and they will each have a go to present their topics, and then after that we'll have a session of questions. So I would request you keep your questions, and we shall have a Q&A session at the end. So you are most welcome, but also I would like to welcome our esteemed speakers. Thank you for putting in time. And my name is Professor Charles Ibingira from Makerere University. I'm a general surgeon, and I deal so much with NCDs. You know, surgery plays a very big component, especially when you are dealing with cancers and other NCDs. So I'm privileged to chair this session. So with me, I have Dr. Emilia Noor Mohammed. She's seated just next here. She's a parasitologist at the Université d'Eduardo Mondlane in Mozambique, and was the only female principal investigator receiving a medical education partnership initiative, that is MEPI. She got an award, and she has led that work for the DCP3 on building surgical systems. So you are most welcome. Our other speaker is Dr. Alfred Muteta, seated at the extreme end, and he's a consultant from Tanzania. He's a surgeon, a urologist. He's also a dean of the medical school at Kilimanjaro Christian Medical College in Moshi, and he's the vice chairperson of AfriHealth and vice chairperson of the College of Surgeons of East Africa, Eastern and Central Africa. He's the country representative for Tanzania. And also we have Dr. Ximena. She's a former Minister of Health in Ecuador. She's currently a public health expert. She's the Dean of the School of Public Health in Ecuador at the University of San Francisco in Quito, Ecuador. She's a former minister. And lastly, we have Dr. Keith Martins. I think you all know him. A physician, former 6-term Canadian Member of Parliament, and is the founding executive of CUGH. So let's welcome them with a clap. So the topic we are going to discuss this evening is on non-communicable diseases. And NCDs are the leading cause of mortality and morbidity worldwide in the current times. They cause nearly 86% of premature deaths, and most of these occurring in low and middle income countries. Yet, NCDs receive disproportionately less funding and political support than other global health threats. We know how to prevent, to detect, treat most of these diseases. Now, how can we implement what we already know will save millions of lives? This panel will share how reforming health systems, strengthening governance, and public institutions that impact not only on health, but the broader social determinants of health, and will dramatically reduce NCDs. But this will also reduce infectious diseases and improve socioeconomic outcomes, evidence-based solutions for the challenging political environment the world is facing now. And we are going to have presentations from our panelists. I beg that you pay attention, and we are going to begin with Dr. Emilia, and Dr. Emilia will present the importance of strengthening surgical systems to address NCDs. She will also address the needs, the gaps, and how low and middle income countries are seeking to address these gaps. Dr. Emilia, you have about 8 minutes to run through this. Thank you.
Thank you, Professor Charles, for this nice presentation. It's challenging. Good afternoon, everyone. First of all, I would like to thank it and the CUGH committee for inviting me to share what is our experience. So, as Professor said, I am a human parasitologist, so I'm not directly linked to NCDs. But I am also MEPI, PI, and later on HAPPY PI, which is the biggest global initiative we have in Sub-Saharan Africa. Okay. This is the outline of my presentation, which is very short: Mozambique country's profile and disease, the weight of NCDs in Mozambique and risk factors, how we are trying to address these issues, achievements and challenges, the ways forward. As we well know, Mozambique is located on the southeast coast of Africa. It ranks amongst the top 5 African countries most affected by climate changes. It has a population of 30 million, and the majority is poor and live in rural areas. It has also one of the lowest numbers of health professionals. The disease profile in Mozambique is dominated by HIV, infectious disease, HIV, malaria, several other infections, and neglected tropical diseases, where I mostly work, and most of the time I'm talking to my colleagues, because neglected tropical disease like schistosomiasis, like neurocysticercosis, also are etiological causes of some of NCDs. And for this, I always advocate that we should work in an integrated way, but it is challenging. Furthermore, the mortality, it is at increasing. And to make it worse, the country has, since the independence in 1975, has had different army conflicts in different regions. And recently, though it is well controlled, in the most rich province in the country in the north, we have this phenomena of terrorism. You are all aware about the numbers in terms of NCDs. The majority of deaths occur in low and middle income countries. And in this slide, I borrowed from my colleague who works on it, cardiologist. And as we can see, we are not the profile of the main cause of the morbidity and mortality are the same as in the other countries: cardiovascular diseases, chronic respiratory diseases, malnutrition, and you have seen previously the high rates of malnutrition that we have. So, but also there are some cancer disease which are much more specific in terms of liver cancer. We are the countries which has the highest prevalence on it. So this slide is just to remind about the main risk factors for some of the NCDs: tobacco use, physical inactivity, unhealthy diet, harmful use of alcohol, and how we have done in the country to address the social determinants of health. Since the profile disease of Mozambique is dominated by infectious disease, for many years we didn't pay much attention to NCDs, but starting in 2002, there was a ratification of the protocol of SADC Health. And for the first time, so it is recent, relatively recent, the first time under the Ministry of Health, there was a creation of NCDs department at Ministry of Health. And following that, some policies have been developed. And to date, we have the National Policy for Health Promotion, because tackling these NCDs, it's about the prevention, diagnosis, but also promotion. And this is the report that we created supporting the Ministry of Health efforts, and also with the participation of the Research Support Center MIER, which was created under Medical Education Partnership Initiative. And in this report, there is all background about the past, the present, and the future of NCDs in Mozambique. So, this I borrow also from somewhere, these slides you sent me this morning. I will not just to remind you and introduce to my next slide in terms of what are the challenges and way forward. So apart the general challenges that every country faces to tackle the NCDs, I will I will be more in these points, which are the limited financial and human resources to implement interventions and policies. Just to say that about 70% of states' budget for health comes from the donors. So it is really a big issue. Poverty, as we have seen, it contributed a lot to NCDs. The army conflicts and terrorism that I talked, the increased urbanization and natural disasters. This increased urbanization, it's also worsened by the army conflicts, terrorism, and the natural disasters, and will conclude to undermines healthcare, education, social and community, economic growth and stability, and build a healthy environment. I brought here pictures of the recent cyclone that we have. We had floodings, we have the Fred cyclone, and you can see crops that have been destroyed, houses destroyed, people cooking in a very poor condition, health units destroyed, schools destroyed, and people displaced. All this contributes first to to stress and mental disease, which is one of the you are looking at one of the, this is the last one of the key problems we have. So what we are doing, what we've been doing with support of all of our funders and partners is to address all these different challenges to bring these beautiful smileys you see here by scaling up training of health professionals and including allied disciplines for diagnosis, prevention and promotion, doing research capacity development aligned with local priorities and contexts, including mitigation of effects of natural disasters and armed conflicts due to the vulnerability of our country, advocate among policymakers and other stakeholders, attracting more collaborations for funding research capacity building initiatives within the country and the region. And so far, mainly thanks to this global initiative that you heard about this morning from Dr. Roger Glass, the MEPI, and the NEP initiative, we were able to attract more than 35 partners that are working with us in different areas of NCDs, training, health professional, research, and institutional capacity building. Thank you so much for listening.
Thank you, Emilia. She has ably discussed or informed us about the law health professionals that are there in Mozambique, and that most of the dominating diseases are infectious diseases, especially HIV. And she went through the risk factors for NCDs, mainly lifestyle, and the issue of conflicts also brings in the issue of surgery, which I think Alfred will also talk about. I think Mozambique is still a country with war. I think so. So let's turn to Dr. Alfred Muteta, who is going to address how we can strengthen training and capacity building in low and middle income countries for non-communicable diseases. Thank you.
Good afternoon, ladies and gentlemen. I will be talking about the surgical importance with respect to NCDs and how our countries are addressing the gaps which are present. So surgery has been playing a major role with respect to NCDs. And of course, there has been significant gains in lower and middle income countries for the past quarter century with regard to progress. But this has not been uniform. Mortality and morbidity from common conditions needing surgeries have grown, and especially in the lower and middle income countries. So, looking at what is it that we are missing at the moment to be able to have tangible contribution of surgeries in managing NCDs. Surgical services are poorly developed, and there has not been significant investment in surgical services in lower and middle income countries. And this has become much more clearer or impactful with increasing NCDs in our countries. Of course, we know that things like cancers, road traffic accidents, and also cardiovascular diseases, metabolic diseases, some of them need surgical interventions. And this has to be inbuilt in the health system, which has not been the case traditionally. Surgeries were especially done at higher level hospitals, at tertiary level hospitals, but at primary health care, surgeries were not done. At the moment, if you look worldwide, 5 billion people do not have access to safe surgeries, almost. But 143 million surgical procedures need to be done every year, worldwide. But in addition to that, just to emphasize on the cost, that almost 33 million individuals face catastrophic health expenditure due to payment for surgery and anesthesia care each year. Surgery is expensive, and we have not invested enough in it. And some families may go completely broke because of surgery, need for surgery. Investing in surgical services in our countries is actually cost effective. It saves lives, but may also, or will also, promote economic growth. And this is what I'm advocating here, and especially for people who are from the lower and middle income countries like Tanzania, where I come from. We realize that definitely surgery is indivisible and indeed indispensable part of the healthcare system. We realize this fact, but we have not internalized it to the extent of including surgery, surgical services in primary healthcare level, but rather at the apex hospitals. Economic consequences of untreated surgical conditions give us a lot of trouble. Disabilities which could have been easily prevented or treated by surgery, but they are not done, and therefore we end up with these serious disabilities. We have failed to integrate, so to speak, surgical services in the health systems, and especially the primary level health system. But as you may know, at the moment, in most of the developing world, lower income countries, non-communicable diseases have overtaken communicable diseases as the predominant global disease burden. So at the moment, NCDs make up almost 3/4 of all death worldwide. But at the moment, we are investing more money in infectious diseases more than in NCDs. If you are to take, for instance, HIV/AIDS, malaria, tuberculosis, well, it takes a large chunk. It's not that it's important, it's very important. They are important, truly, but also the surgical conditions, which get as little, actually the NCDs get just around 1.8, 2%. They contribute a lot to our ill health. But what should we be doing? We should actually, we know already that surgical care systems are an important component in the treatment of NCDs, including cancers, cardiovascular diseases, trauma, maternal and child health, and they provide a solid foundation for healthcare systems. And therefore, I want to say to you who are attending today that at policy level, we should try as much as possible to sell this concept, that surgery is actually life-saving, and it's not a luxury to our communities. It's something which we need, and it can save at primary prevention and even secondary prevention of NCDs. And therefore, actually, we don't need to reinvent the wheel. We already know, we have significant knowledge, and we know that if we invest in health systems, which include surgical services, will save a lot of lives. I don't want to go into telling stories about this matter. Many of you may have already seen it. So we need actually to build surgical care systems, and we must shift current funding thinking not just on infectious diseases, but also in surgical as well as an entry point for NCDs. And investing in surgical care can also produce sizable economic returns. You have healthy people and people who can contribute to the economy by investing in surgical services at primary healthcare level. And in the lower and middle income countries, here I'm talking about health centers and dispensaries. Health centers, these are primary healthcare facilities which serve around 50,000 people catchment areas. We need to be able to make sure that the health centers can provide basic surgical services, including obstetrics and gynecology, operative delivery, etc., etc. And this is worth doing, and it's worth the money which we may invest. This is the take-home message I wanted to give you, ladies and gentlemen. And well, some of you may know this picture, but this is where I come from. You can see the snow and the permanent frost at Kilimanjaro, which stands at about 20,000 feet above sea level, just south of equator. Thank you so much for listening to me.
Thank you, Dr. Mteta, for outlining the role of surgery. Actually, surgery plays a very big role. I think it provides cure for most of the cancers. But because it is not at primary healthcare level, most of the cancers present late, and therefore you are not able to offer curative options. You only do palliation. But if it can be instituted at primary level, we can pick all the cancers early and give them curative surgery. There are other aspects of NCDs like mental health. He has outlined the accidents and the maternal and child health. Cardiovascular also requires surgery. And it is very evident that there is low investment in surgical care in most of the low and middle income countries. So with that, let's continue with our panelists, and this time I would like to invite Dr. Ximena, the former Minister of Health of Ecuador, and she will talk about what is needed to strengthen health systems in low and middle income countries to address NCDs. Thank you.
Thank you very much. First of all, I want to thank Keith for the invitation and also for the wonderful organization of this event. I want to talk a little bit about the framework of NCDs in Ecuador as an example of what is happening in South America. My name is Jimena Garzón, former Minister of Health of Ecuador. Currently, I am Dean of Public Health at University San Francisco de Quito. I have a PhD in public health and occupational epidemiology, and well, for me, it's a real pleasure to be here to share this experience with you. So, as we already know, this is the leading cause of death in low middle-income countries in the whole world. We see here that we have ischemic heart diseases, stroke, neonatal conditions, chronic obstructive pulmonary diseases, lower respiratory infections, and there we have a lot of problems with infectious diseases, and again, some problems with non-communicable diseases. And the same is happening in my country, in Ecuador. So the first leading cause of death is ischemic heart disease. Then we have diabetes mellitus, stroke, influenza, pneumonia, which is very odd because for women in Ecuador, this is the fourth cause of death, but not for men. For men, the fourth cause of death is hypertensive heart disease. And the contrary, influenza and pneumonia for women is the fifth cause of death. Then we have road injury, which is very bad. We are one of the countries that has, I mean, it could be in the middle rates of road injuries, but because of the public transportation problem, a big problem in our countries, we have a lot of deaths related with road injuries. We have cirrhosis, kidney diseases, which is a very bad problem also in Ecuador. Every month we have 200 people who becomes chronic disease failure patients, new patients every month, which has been a big economic toll for Ecuador because each one of those patients costs about $1,500 per month. So if you multiply 200 by $1,500, you can calculate how much is costing to Ecuador every year per patient this fatal disease. Ecuador is a very small country. It's about the same size of Florida. We have 17 million people living there, so you can calculate how much is the problem. We have another kind of diseases like chronic obstructive pulmonary disease and neonatal conditions. So, as my colleagues here that comes from Africa, we shared more or less the same problems. Low middle-income countries are in epidemiological transition. So this makes a very complicated management of public health because we have two problems, right? Two sources of problems. We have non-communicable diseases, but also we have infectious diseases. So the management of public health becomes really, really challenging. We can't let behind infectious diseases, but we have to think about NCDs because you know that it takes a long time to develop these diseases. So we have to prevent them because it's easier, it's cheaper, and it's more effective to prevent than to treat. More, if we think about that as low middle income countries, we don't have enough resources. So it's very expensive to treat. We have to be more effective preventing these kind of diseases. And we have to take into account the social determinants of health because they have been negatively affected after the pandemic's COVID-19. They have increased. Ecuador registered 75,000 excess in deaths from March 2020 to July 2021. And that, of course, made a very deep economic impact in Ecuador, in the economy of Ecuador, and I'm sure in the whole world too. As you can see here in this table, 34% of the household heads were affected because of the pandemics. 45% in the age from 30 to 49, 47% of the heads of the households between 50 and 64 years old were also affected. So if we take into account these social determinants of health in the upstream level, we can see and we can analyze what happened in our countries. Availability of social services, for example, in Ecuador, we have the Ecuadorian Institute of Social Security, which was very affected because the contribution, because many people lost their jobs, the contribution decreased. And that had an impact in the public health sector in Ecuador. The Ministry of Health has a lot of hospitals, is the bigger system, health system in Ecuador. And as the Ecuadorian Institute of Social Security, because this Social Security owns a lot of hospitals too, they didn't have enough resources to maintain the health system. All that load of patients that were complicated because of the lack of attention, healthcare during the pandemics, changed from the security health system to the public free system in Ecuador. And that affected deeply the health system. The health system became completely insufficient. We didn't have enough treatments. We didn't have enough equipment. We really struggle with the health system. And indeed, right now, we're still struggling in the public health system in Ecuador. As you can see, social determinants as formal jobs also had an impact. Household income decreased, the poverty increased, the violence also increased. And that caused and was related with another kind of NCDs like psychiatric problems and depression and self-injuries. The ability to obtain quality of education also had a deep impact. The quarantine and the lockdowns and poor internet access impact directly in education. Children were not able to go to school for about 1.5 years. And they were subject of violence, intra-domestic violence. And it's a pity, but we are gonna see that aftermath perhaps in 10 years or less than that. So we have to be prepared also for that impact. If we are very aware of what aftermath, what impact of NCDs, besides diabetes, high blood pressure, chronic renal failure, etc., we're going to have a lot of problems with psychiatric and these problems that some of them are not visible, right? As I said before, the access to quality healthcare in my country, the health system collapsed. There was a bigger demand in the public system, and also the NCDs increased because most of the patients didn't have access to healthcare for more than 1 year. The severity of the diseases increased. Most of them, perhaps if they had a good healthcare, wouldn't become chronic disease, chronic problems, right? What we did in Ecuador is we developed a 10-year public health program, which is a program interinstitutional and intersectoral, very, very close to the program that you have here in the US, which is leaded to prevent, to work with other ministries, not just, this responsibility is not just of public health, is interministerial. It has to be the responsibility of education, the Ministry of Education, the Ministry of Ambient, the Ministry of Work. We have to work together. It's the only way how we can prevent NCDs and to overcome to this pandemic that was a tragedy for the whole world. We are also trying to promote education for primary healthcare workers, which are very important because they are in touch with the community. They are part of the community. It's very important to work with the community because they have to be empowered of what are their needs and what are the most important things to cover their needs, and also because if we are developing these interventions, they should be taking into account their customs and also their beliefs. Okay, thank you very much. So the downstream effects was lower physical activity, like in everywhere else in the world, which increased NCDs. We have more violence, which could be intentional or unintentional injuries, more use of alcohol, tobacco, and substance, which are translated in more NCDs, and also intentional and unintentional injuries. I was part of the Ministry of Health, head of Ministry of Health, in the middle of the pandemics. And we had the job to vaccinate 9 million people, more than 65% of the population, in 100 days. And we did it in 93 days. This is not an NCD, but I think that the way how we manage the pandemics, how we control the pandemics, and the successful vaccination program that right now has around 85% of the total population from 3 years old and older in Ecuador was very important because we could stimulate the economical production in Ecuador again. So that was very important to get back to normality. So thank you very much, and thank you again, Keith, for the invitation.
Thank you, Shimona, for your presentation. I think she was able to share with us the issue of chronic renal failure and its causes, and how it is bearing on the economy. Then the role of prevention in NCDs is very important. Worldwide, it is easier to prevent than to cure. And then the role of the issue of psychiatric conditions in Uganda, I think they are going up. And she also outlined the importance of multi-sectoral approach in managing NCDs. So let's end by listening to Dr. Keith Martins, who is going to talk about bridging the research, implementation policy, and those gaps, and the financial reforms to address NCDs. Thank you.
Thank you so much, Dr. Bangura. Haven't we had a wonderful panel here today so far? Fantastic. And from all of us at CUGH, every single person here made, as you can tell from where they come from, made enormous sacrifices in time and resources to come here. And we just are going to say we're so grateful for what you are doing to be able to make that investment. And anyway, from all of us, thank you very much. Now, what I wanted to do, folks, we have a little bit of competition next door, but those folks should be in here, as all of you know, because you're much smarter than they are, right? We're dealing with the bigger, much bigger fish to fry. And what I wanted to do with you is tying the wonderful presentations that we've heard here today, the hard solutions that we have spoken about. Let's pull it together and see how we can make this happen. So let's start. So Amelia, we're obviously on the same page on this. And often we neglect so much of this, right? We neglect the social determinants of health. The stuff that all of us know in our patients that have a huge impact, but structurally and politically are often neglected, whether it's the education that was spoken about, whether it's poverty is dealt with, whether it's food security, whether we're talking about violence and state security, whether people are safe to walk down the street. These things are not considered partially, but much of them remain orphans in what we do in global health. And we need to change it to address the non-communicable diseases. The other part I want to talk about that we really neglect are the political determinants of health. And Dr. Garçon, as a former Minister of Health, spoke about this. And let me tell you a little story. I was part of in my last job as a member of Parliament, I was part of a small group of senior politicians from the Commonwealth nations. And we went to a country where the lifespan had plummeted from the 50s down to 33 for a man and 28 for a woman in a matter of a few years. The reason for that is that the leader of that country had weaponized their food system. That person had chosen to deprive individuals in that country from accessing food. Now, that country has a very high HIV rate, so they need about 2,000 calories a year. So you put food insecurity on top of people who are already immunocompromised, and you get a catastrophic decline, one of the fastest declines in lifespan ever. Now, that wasn't a matter of having a health system that didn't work, but that was a deliberate political attempt to actually harm people who were not voting for that particular leader. And I use that as an example because I want to reference that if we do not deal with the political determinants of health, and I know it's uncomfortable for many folks in our world, particularly in academia, we shouldn't get involved in politics. But I'd submit we need to make a different understanding of what is politics versus what is being partisan. And there's a difference, as we know. So don't be partisan, and we have individuals here with a lot of experience in politics, but we need to be political. Because we're not involved in the political space, we cannot get what we need to get done to address the challenges we're talking about here. And I want to talk about our friend, Professor Francis Amaswa from Uganda. Now, Professor Amaswa was at the AfriHealth meeting a few years ago, and he said, "Keith, take this book. This book is a handbook for ministers of health, short and sweet, but it's priceless." And I'll only say one thing in here that he references. He says very clearly that we need to be addressing the structural deficits that exist within government ministries. Not only in ministries of health, as Dr. Garçon mentioned, but also ministries of education, as I think Dr. Nur Mohammed mentioned, whether it's the ministers of health, of course, as Dr. Mteta and Dr. Makerere mentioned, but importantly, ministries of finance. Because where's the power, right? The power at the cabinet table is not at the ministries of health, they're at finance and defense and the Prime Minister or President's office. That's where you have your pressure point. So when we do our work, we often deal with, I call this, with greatest respect to Dr. Rudolf Virchow in the Pyramid of Needs. I took this and reformed it and I call it the neglected foundation of development. So let's visually take a look at this. Often we are talking right about the top of that pyramid. We put in programs to address the sustainable development goals, right, whether it's biomedical or non-biomedical. But if you wanted to implement a program, whether it's dealing with cardiovascular problems or surgical systems or education, what do you need to have? You have to have effective public institutions. You've got to have effective ministries, right? And those ministries are neglected, and that's what Professor Maswa said. We do not pay attention to working with governments to strengthen that capacity, and we do it at great detriment to our ability to deal with the challenges at the top of the pyramid, to achieve those sustainable development goals, to address the NCDs. We often, if we do anything, we might engage with the ministries of health, but we often ignore public works, and importantly, we ignore finance and justice departments. I say that because if you don't have strong finance departments, if you don't have strong justice departments that are independently exercising the laws of the land, what do you have? You get a situation where people are not protected, where people are subject to great abuse. And if you look at the countries that are most vulnerable in this world, where conflict has occurred or is occurring, they have some things in common. They have weak governance systems, they have autocratic systems often, but they certainly have weak finance and justice systems. And they don't have the independent oversight that is necessary for their citizens to know where their money is going and being used for. So I said there's key gaps in the NCDs, of course, in government capacity. A sufficient number of skilled workers, and we've seen the deficits here. I think it was Dr. Mteta spoke about the incredible gaps Dr. Ibngira and Dr. Nur Mohammed has. It was pretty striking when you spoke about the number of surgeons in a country, right? It was 0.4 to 10,000 physicians. That's shocking. There's a lack of sufficient number of skilled workers. And there's a lack of number of skilled workers often in government ministries, which we ignore. Skill gaps. And Professor Maswa spoke about 3 specific skill gaps. And if we can take this back to our institutions and share that, it would be incredible. Skill gaps are governance, management, and leadership. And infrastructure, reliable broadband. We are all on conversations, right, on IT with colleagues in LMICs where the broadband doesn't work. And we have to stop those conversations because they don't have access to broadband. That's the digital divide. And then being self-financing. Now, the benefits of strengthening the foundations of development, and Dr. Tim Evans, who collaborated, wrote the foreword about that and had some very good comments about that in this. The benefits of strengthening that foundation of development that I spoke about is that it improves governance and oversight. It strengthens the economy, creates jobs, and it reduces corruption. When we go to meetings and it comes to who's going to pay for this, right? What does it usually discussion fall into? It falls into aid, right? Often aid, official development assistance. But the amount of money that's been hemorrhaging from low-income countries year after year after year to the amount of 1.5 trillion, with a T, dollars every single year is hemorrhaging from low-income countries. That's theft from those countries and those people and those citizens. That money isn't parked in those countries. Where does it go to? High-income countries. It's parked in our systems. Nefarious people, corrupt people, use our financial mechanisms and systems to launder $1.5 trillion a year. Well, that number is interesting. Because guess what it costs to actually fund the Sustainable Development Goals every year? $1.5 trillion. Now, I'm not making that number up. That comes from the former head of the IMF, Christine Lagarde, who lamented this. And that's the number. And she has said very clearly that we have to strengthen the foundations of development, work with countries, work with them. They know what to do to empower that. Because if we do that, security will be increased, disparities will be reduced, lives will be saved, it reduces disability, saves money, and that is smart politics, right? So just to say that when we leave here, if we can work together to build relationships, collaborations, and partnerships to strengthen that in terms of human resources, in terms of across those biomedical and non-biomedical ministries, will do a lot. Now, Dr. Andrew Dykins is here. Andrew, raise your hand, please. Please say hi to him. He's got a card that he was kind enough to put together. That card has a capacity building site that Dr. Dykins helped to create for us. And that capacity building site enables countries to identify trainers to meet their training needs as they see fit. So please get a card from Andrew, because that's a really important activity. So pretty much in closing, I had a couple more slides. Opportunities for academia, education capacity building, align our research with contemporary challenges that people want, communities want, and advocate with public and policymakers. And building the partnerships amongst ourselves, we'll be able to do these three things. And just in getting to yes with politicians, right, know that their horizon is the next election. So if a couple of short things, understand their interests, understand their objective is to get elected, know that their time horizon is the next election, and look at, for them, their priorities, frankly, we like to talk about lives saved and health and equity, but in reality, what is their interest? Politically often. Jobs, a strong economy, security. Those are the three most important things. Health might come in later, but that's often not their top priority. That's where the power lies. If they can go to their constituents, say they're creating jobs and have a better economy, they know that they have a better chance of getting elected. So we need to shoehorn what we're doing, understanding that. And I think we have a strong argument that we've heard here that addressing NCDs is smart politics. It does improve the economy, as Dr. Mteta said. So finally, my last slide on this is that an area of deep neglect. This is a picture of a rainforest. It's being destroyed. But what you see is that there's particulate matter that's going up in the air that affects pulmonary and cardiovascular problems. The destruction of the land reduces food security. So you're getting into diabetes and an array of the other NCDs. It also affects people's mental health, the leading cause of disability in the world. But if you actually address the planetary crisis of the destruction of ecosystems, if you provide green space, if we can reduce this, not only is there an enormous impact on non-communicable diseases, which is evidence-based, but it also addresses the triple planetary crisis of climate change, biodiversity losses, and pollution. So I'll close there. Thank you very much for your time. And this is also a shameless promotion for Bolsa Familia from Brazil, a fantastic program that reduces poverty. Anyway, thank you for your attention, ladies and gentlemen.
We have managed to save some time for questions, and now I would like to invite questions. We'll have a few questions first, and then after that we get more questions. So, yes.
Hi there. I'm Liza Dunn. I am the Medical Affairs Lead for Bear Crop Science. I really enjoyed this discussion. I think it's really important. One of the things that I didn't hear a lot about was agriculture. And agriculture is the foundation of civilization. When you get efficient agriculture, you decrease deforestation, you increase your ability for kids and women to get off the land and get educated and become part of your workforce. So if you really focus on that, that's important. It's also important in terms of NCDs. In Mozambique and in Ecuador, two of the staple crops are maize and cassava. And it turns out that using agricultural techniques that aren't very advanced increases your risk of aflatoxin poisoning. And that's a leading cause for liver cancer. Liver cancer kills 900,000 people per year, and it also increases your risk of kwashiorkor. So what I would encourage folks to do is engage also with the agricultural sector to come up with collaborations that help with best practices in agriculture, so we don't have an ounce of prevention is worth a pound of cure. So we can get best agricultural techniques to prevent these diseases from happening. And I don't know, do you and your countries have ways of interacting with your agricultural health ministries? And is that part of your public health plan?
Thanks for that compliment. Yes. But I think you'll make a comment on that also. Yes.
Greetings everyone from the beautiful city, Freetown, Sierra Leone, with the beautiful white sandy beach fronts. The name here is Sheku Dennis Masakoy, MD, IVLP alumni USA, a practicing general surgeon and a specialist diabetologist with special focus to diabetic foot medicine. I will first of all want to commend Keith Martin, MD, PC, and the team for putting such a wonderful session together. Of course, for the panelists, top notch. If only we could understand the presentation from Keith Martin, and we could have leaders in these low, middle income countries that have the medical bearing, then most of these problems with regards to NCDs, the suffering and the likes will be over. That said, my question now is for the other presenters. You can comment and then see how it goes. The question is, how pivotal or how useful is the drive for spreading out multidisciplinary health institution targeting NCDs? In the sense, they could be affordable but with greater impact. In the sense, they will cater for the management of conditions pertaining NCDs, and also in this same multidisciplinary health complex, another section dealing with the educational aspect, structured educational aspect as to how we prevent some of these conditions. Okay, that's also included in organizing sessions for their routine exercise and the likes, all towards preventing some of these NCDs. This I could say, okay, for diabetes alone, thinking about the dreadful long-term complications, you have the retinopathies, you have the diabetic foot, you have the renal impairment. The list goes on. So by having this single complex, you not only handle the cases, you also have a section where you educate people how to prevent some of these conditions. They could be minimal in cost, but with greater impact. Of course, we always remember the scale, okay? Inputs and then profits, see how it goes. So with that said, I would just want to close by saying, or quoting the famous American physicist, John Archibald Wheeler, we live in an island surrounded by a sea of ignorance. And as our island expands, so does the coast of ignorance increases. So such a setting, I'm confident we are, in a way or another, contributing in expanding our land of knowledge. Thank you very much, panelists. Thank you very much, Keith Martin, and your wonderful team. Thank you all. That's the question for the panelists.
Thank you. Let's summarize our questions and comments. Next.
Yes, hi. Thank you so much for this wonderful presentation. My name is Barbara Kamholtz. I'm a geriatric psychiatrist, and I'm working with the help of partners in CUGH on building geriatric capacity in Nepal. And I just wanted to make a plug for dementia as a non-communicable disease because it is incredibly prominent. In the US, it's a very significant rising cause of death. And in low and middle income countries, it's increasing at a rate 3 to 4 times that of high income countries. And there are absolutely almost no resources in geriatrics in LMICs. So I just wanted everybody to remember that's in the NCD list because we often leave it out. As best we know, it is commonly not a communicable disease, although there may be some genetic issues, but certainly in every other way, it's something we just need to keep our eyes on. Thank you.
Thank you. I think geriatric disease is part of the NCDs. Thank you for that compliment. Let's have one more.
Hi, my name is Professor Rajiv Chaudhary. I'm the chair of the Global Health in Florida International University in Miami. I was really so impressed with this discussion, and especially what Dr. Martin said, the structural risk factors are so important to characterize. I was just wondering, I mean, listening to our colleagues from Ecuador and Mozambique, dealing with NCDs secondary to climate change, for instance, or mental health problems, as the colleague in Ecuador mentioned. So do you see the other missing bits, for example, the so-called commercial risk factors of NCDs, the so-called private bodies which shape the determinants, the risk factors of NCDs, even the outcomes. And the other missing aspect, perhaps, which is important to highlight is the engagement of the communities, because both these domains, both commercial entities operating within a country as well as the communities, they influence the structural factors of the disease, I think, quite potently. So I would be quite keen to, listen to both of you about those two aspects as well. Thank you.
Thank you.
You can go for it.
Thank you. My name is Julie Hard. I'm from York University in Toronto, Canada. And I was struck by the fact that each of the speakers, even in the nature of bringing low middle income country and high income country, have discussed the economics around this issue and the politics of the economics. So just as an example, the need for surgery in low and middle income countries as a plug was one thing that was said and brought up and brought forth. And also the issue of corruption, siphoning funds out of low-income countries into high-income countries where the money ends up being. So my question is really more to ask you as panelists if you have suggestions about how we can actually challenge some of the economic structures within high-income countries and be allies to resourcing and providing the supports where they need to be. Particularly in non-communicable disease context, which kind of takes a back burner as always present, but not necessarily brought to the forefront. Thank you.
Thank you very much. I think let's first respond to this, and whoever is ready can.
Okay, thank you very much. Okay, I agree with you, absolutely. I think that agriculture is completely necessary to improve the food security for all the communities. Indeed, in my country, we, in the university where I come from, we are developing this program that's gonna help to improve agriculture with an application in smartphones, all right? So that's gonna help with commercial commitment, which was another one of the questions, because it's gonna facilitate the trade of agricultural products in rural people, in rural communities. Let's remember that Ecuador has the Andes, the mountains that are very high. The land is not so productive because of the environment. It's very dry sometimes. It's very difficult for them to produce food, vegetables, and everything. So this kind of intervention where we are facilitating the trade of products, we are hoping that we're going to have a good impact in that population. Absolutely. I agree 100% with you. In the National Health Program that was designed during my time in the Ministry of Health, we were working very closely with many ministries, one of them, the Agriculture Ministry, which is very important. Otherwise, we're not going to be able to implement all these interventions. I really hope that the political situation becomes more easy in my country, and as Keith said before, it's very difficult to implement all these great ideas that we have if we don't have political commitment in our countries. So the stability, the political stability is very important. Otherwise, the gaps increase, the violence increase because of the poverty, and all these topics that are so important in the base of any country just are forgotten because everybody is thinking about other things that are not so important and basic like what we are talking today. About what Barbara said of psychiatric diseases and dementia, let's remember that many of the NCDs are also related with mental health problems. So this, as I said before during my presentation, we have to take this very, very seriously because we're going to see the aftermath of the pandemics and the increased gap between poverty and rich and access to health. We're going to see a very bad aftermath in mental health. Absolutely. So we have to work, and I think that as academics, as researchers, we have to think very seriously about these kind of problems because they're going to have a very bad impact in public health in the future years. The community involvement is very important. As I said before, just the community members know what they need, and that happens with us in the intervention of the vaccination plan, because we had in mind just like a cookie-cut intervention that should be applied to everybody. And even though that Ecuador is a very small country with a very small population, we are very diverse. We have a lot of ethnic communities with their own languages and their own thoughts. And we were very successful in our intervention with the vaccination because we went directly to the community representatives, managers, and we talked with them which were the needs of the communities, what they thought about vaccination. And we were speaking with them using translators in their own languages without anything written, because most of that people, they don't read. So they needed the communication to be verbal, to be oral. So that's why we were so successful in this intervention, which is an example of an intervention of public health, because we were developing this program with the customs, the way of thinking, and the needs of the community. So that's what we had to do in every public health intervention that we are proposing. Thank you very much.
Well, as I said, it's mainly about emphasizing on the importance of surgery with respect to NCDs. Agriculture is definitely important, very, very important. There's that concept of One Health, which includes not just looking at human beings, but living in general, veterinary, agriculture, its interaction to NCDs, which is very, very important. But I think we've been insisting here again that whatever you do, you must invest and you must work with our governments. And we need to have governments which follow the rule of law and they are elected properly. And we as health workers or in the health sector, we must be able to work with our governments. Because through the government is where we can make the impact. That's obvious. You don't have to be the minister yourself, but you may use lobbying, but definitely work with our governments. That's very, very important. What's the way forward? Again, we have to work with our fellow countrymen and countrywomen to make sure that we have good governance. Good governance will deal with some of those issues about corruption and siphoning of money out of lower middle income countries to other parts of the world. Well, where I come from, I didn't tell you, but it's one of the few countries where we have a female president. At the moment, we have a lady by the name of Samia Suluhu Hassan, is president of Tanzania, and we are very happy to have her. Thank you so much.
I think you have a question.
Thank you so much. I just want to share another perspective and say that really food security is very important because it impacts on all, both infectious disease, NCDs, and sometimes some of these NCDs have to do with infectious disease. Our experience, the other perspective we have on dealing with food security in Mozambique, and well, we just came from San Diego where my husband is there, was Vice Minister of Health, but also governor in different parts of the country. He was sharing with our colleagues in San Diego about the disasters management. Due to this vulnerability in climate change or in our countries, and also the conflicts, the army conflicts that we've been gone since the independence, and terrorism. At a certain point, I can't remember the year, the government created, well, it grew gradually, but now we have the National Institute for Disasters Management, which is under the high level, the Prime Minister and Head of State. And one of these tasks of this institute is really to oversee about disasters, food security, and so on. So this is another way of tackling this challenge of NCDs. Sorry, yes, that's it at the moment.
Dr. Keith, you will summarize, but let's hear more questions.
All right.
If you can summarize your questions.
Sure. So actually, it's not a question. It's a proposal for all of us. My name is Daniel Van Stock. I'm an advisor for ministers of health in Latin America. I live in Brazil and advise I think the microphone is a bit okay. I advise the Minister of Health in Brazil, in Peru, and in Colombia on how to promote high-quality health care to people living in poverty. So, for instance, the program you showed on your last slide, I was one of the advisors that relaunched this Bolsa Família program to help low-income communities living in slums, in small cities in Brazil, to have access to high-quality to high-quality healthcare. And I use a approach to my work that's called radical listening. So I go to the communities, I go to public hospitals, I go to slums, to small cities in Brazil, and I listen to the stories of black women and people living in poverty to really understand what are their needs, their priorities, their main barriers to access to healthcare. And what I've seen is that it's much more than only access to drugs. It's access to safe housing, to food, to education, to jobs. So for instance, the Minister of Health recently launched a telemedicine service to help these people, but one of the main challenges was because they don't have access to high-speed internet, so they couldn't access to this telemedicine service. Or, for instance, many of these low-income communities, they can't access hospitals, not because they don't want to, but because they can't afford to buy the bus fare to go to the hospitals. So listening to the communities and understanding their realities, their life stories, their needs, it's really important to build better policies and laws. So nowadays, I feel that the vast majority of lawmakers and policymakers are people like me, so white, straight men, high income, and we really need also to change the type of people who are on Congress. So we need more women in Congress, we need more people of color in Congress, and we really need to listen to the needs of the communities to build better laws and better policies. Thank you.
Thank you very much for that compliment.
Yes, Jonathan Patz, University of Wisconsin. I want to tee off of the last presentation. Keith talked about the multiple global crises, poly-crises that are happening today. And if we recall, every crisis presents an opportunity. And if you were to add up the mortality from fossil fuel-based energy, from high-meat diets, and from sedentary lifestyle, especially from private automobiles, that adds up to almost one half of the 50 million people that die prematurely every year. So my question, and it sort of relates to the agricultural question, but it's a broader question of, in this time, in this age where we find ourselves with these global environmental challenges and pandemics, that it really requires way more collaboration across sectors. And so I wonder about your approaches that are truly cross-sectional and across ministries, and how that's, how that can be promoted towards prevention.
Good afternoon. My name is Hui Jiaoyan. I'm from Peking Union Medical College of China. My question is, when we are discussing global health, there are many topics like health equity and infectious diseases. These are two big parts. These are very big. So do you think we get enough attention on NCDs when we're talking about global health, especially in low and middle income countries? If not, what can we do to get more attention on NCDs in low and middle income countries? Thank you, that's my question.
Keith, you answer that. And lastly?
Yeah, thanks. Jawad Noon from University of Göttingen in Germany. In an ideal world, we would like all the non-communicable diseases to be treated or to be cared for at the highest possible level. But we all know that that's not possible because of certain reasons. I'm a medical doctor and currently in an economics program. And economists, for the right reasons, are obsessed with using the resources in the most efficient way. And I've been in global health for a number of years now. One thing that I haven't been able to grasp is that there are so many non-communicable diseases, and how to approach that one point where we can have the maximum results in the face of limited resources. And I do understand that will require research, lots of research to actually figure out like how to do it. But what I would like the esteemed panelists to comment on is how to approach that one particular point where we know that, and this is the point which is of the maximum benefit for all the non-communicable diseases that are all around there. Thank you.
Thank you very much. Let me request Dr. Keith to respond. There are a number of economic questions and
I should ask our former Minister of Health to do it. She'll know more than I will. But those are amazing questions because you interrogated a lot of what we said. We can't go through all of them, but just a couple of things. One is Dr. Pats mentioned that a crisis is an opportunity, and this is an opportunity. What's interesting is Dr. Chowdhury spoke about the commercial determinants of health. But the commercial determinants of health are attached to the political determinants of health, attached to the social determinants of health. It's an ecosystem. They are indivisible. And if we had to do one thing, if I could submit and plea for all of us, is that we need to focus on building and strengthening the capacity of government ministries, not only ministries of health, but in finance and justice and environment and public works. If that's strengthened, and it can only be done, frankly, in a government that wants to do it. If they don't want to do it, it ain't going to happen. So you have to be, it's got to be with the willing. And many people want to work with us. So that's the first thing. The second thing is on the value proposition. There's an incredible value proposition. We're lucky to have Dr. Satish Gopal here from NCI and Dr. Ted Trimble. They've put forth amazing research that actually shows value proposition on the area of cancer, right? And we heard from our members on this panel that there's a strong value proposition. What we do a really lousy job of doing is we advocate really poorly. It's really bad. We are not consistent. We are not persistent. We don't present the value proposition that we know and have. And we don't build relationships with those in politics to be able to work with them effectively. And nor do we engage the public effectively, I believe. We don't communicate. We communicate in our language. We don't communicate in the language, I would submit, that the public understands or politicians understand, because most of them are generalists. They're not, we're physicians all up here, but most of them are not. So we have to go to them, and as I mentioned in my slide, understand their incentives, deal with those incentives, argue using their incentives. And if we're able to do that, then you can bring them in as a partner with us and be able to build those structures. Because if we're able to build that administrative capacity, whether we're dealing with cancer or diabetes or cardiovascular disease or pulmonary disorders or neurodegenerative disorders or injury or other mental health issues or infectious diseases, if we get the structure right, no matter what disease we're talking about, we will be able to address them. But we've got to get the structure right. Anyway, thank you so much, everybody.
Thank you, Dr. Keith, for those concluding remarks. I think we are encroaching on time for another session. I want to thank you for being an excellent audience, excellent questions. Let me also thank the panelists for the good presentations and good response to the questions. Thank you very much, and we end the session.